Okay. Welcome everyone to today's webinar. This is brought to you by the Transdisciplinary Collaborative Center for Health Information Technology Policy at Morehouse School of Medicine. I am Megan Douglas. I am the Associate Project Director for Health IT Policy. And today's webinar is called Increasing Access for Underserved Populations Using Telemedicine. So thank you everybody for being here. And just a few housekeeping notes. All of your participant microphones are muted. So if you have any technical issues, you can use the tech support chat pod on the bottom right side of your screen. We will also be collecting questions from the audience throughout the presentation. So whenever those come up, feel free to type your question in, and we will have some time at the end for some discussion and answering audience questions. So the Transdisciplinary Collaborative Center is funded by the National Institute for Minority Health and Health Disparities. And we have two main components of the work that we do here. We have a research focus to inform policy about the impact of health information technology on health disparities, and we have a practice focus where we are trying to implement those policies and the research findings to advance health equity in practice. You should be able to click on that link to visit our website and follow us on Twitter. The learning objectives for today's webinar are that by the end of the session, the participants will be able to describe how telemedicine is being used to increase access for underserved populations, to examine some policy and practice factors that influence telemedicine adoption and utilization, and we will review a practical example of how telemedicine is being used in the community to advance health equity. I am really excited to have two speakers with us today, and unfortunately it looks like Anitra might have fallen off, but we'll try to get her back up here as soon as possible. We have Sherry Williams, the Executive Director for Georgia Partnership for Telehealth, and Anitra Walker, Director for Behavioral Health with Mercy Care. And I'm going to start out by providing kind of a high level framing some of the issues that we're going to talk about today, and then I will hand it off to Sherry, who will talk about what Georgia Partnership for Telehealth does and give us kind of an environmental scan of the telemedicine environment in Georgia. And then Anitra will talk about some of the work that Mercy Care is doing using telemedicine. So just to start out with the definition, a very basic definition of telemedicine is the delivery of healthcare services over distances using telecommunications technology. So you may often hear the terms telemedicine and telehealth, sometimes used interchangeably. The distinction that I draw for myself in using those terms is telemedicine really refers to that delivery of healthcare services, whereas telehealth encompasses a lot of other things in addition to delivery of healthcare services. And some of that even being distance learning and distance education. So telemedicine is really specific to that delivery of care. And we'll definitely hear from the other speakers today, but telemedicine can be used for many different applications. Primary care, it's being used, behavioral health, dermatology, stroke and triage, intensive care, and school-based health are just some of the ways that telemedicine is being used. But I definitely hope that as an audience throughout this presentation, you're thinking about telemedicine and potential uses very broadly, because the sky really is the limit with that. So the impact on health equity for telemedicine is really great, and it's a really exciting technology as far as that impact on health equity, because really by definition, by nature, it is a technology that can be used to increase access by bringing services to populations where they may not otherwise be available. It also has a huge convenience factor, which I think is one of the things that is also driving the popularity. So for patients who are using telemedicine, it can negate some of that taking time off of work, decrease the travel distance and time, and it's also a way to engage patients. So I think it's beneficial to look at it from, again, that broad perspective and what all can we do with telemedicine. So you may be able to see your patients more often than you do face to face and do more regular check-ins. It's also a way to do a lot of that care continuity and coordination that is challenging to do in person. And then from our perspective within the National Center for Primary Care here at Morehouse, increasing primary care capacity is some huge potential with telemedicine, and things like Project Echo, where the whole goal is to provide primary care physicians with additional skills so that they can decrease referrals to specialists or utilize those referral situations when they're really needed, and in that way also increase access. And then just some statistics on utilization of telemedicine. So we are hearing a lot about it. Policymakers are talking a lot about it. And it's actually not something that's new. It's been around for a long time. And in fact, Medicare started reimbursing for telemedicine in 1999. But we are still seeing a gap with actual utilization. So data from 2012 reported that 42% of U.S. hospitals were self-reporting telehealth capabilities, but we don't know how many actual encounters and how much of that data was actually flowing with those numbers. We know that in also 2012, the Medicare expenditure was $5 million, which is under what was expected and what was allowed through the Medicare program, and 70% of those claims were for behavioral health services. And then this is some of the research that we've conducted, and we looked at over 33,000 Medicaid enrollees in 2008 and 2009 had received telemedicine services, which was equivalent to 0.1% of all Medicaid enrollees in that time period. And 90% of those claims were for behavioral health services. So as you can see, behavioral health is something that it's really being used a lot for, but we will talk about some of those other applications as well. And then just some of the policy issues. Sherry will get into a lot more details with this, but when we're talking about telemedicine, we're talking about policies that impact the practice of medicine or define the practice of medicine using telemedicine. And then we have payment. So that's always the big question that we hear from providers who are considering adopting technology is how are they going to get paid for providing these services? So most of the policies listed on this slide are state level policies other than the Medicare, which you see with the asterisk there. So Medicare does pay for telemedicine, but has some very strict limitations about where those services can be provided and what services. Medicaid obviously varies by state and private payers. For example, in Georgia, we do have a private payer mandate so that private payers are required to reimburse for services that are delivered via telemedicine as they would in face-to-face. Now we do know that practically that is not always the case that happens, at least that the equivalent amount of money is reimbursed. And then there are some licensure issues too, and states deal with licensure for telemedicine in a lot of different ways. Some of those being granting multi-state licenses to physicians so that they can practice within that state. And some states even have telemedicine-specific licensing laws that allow out-of-state providers to practice within the state strictly telemedicine. So I'm going to hand it off to Sherry right now to talk about Georgia Partnership for Telehealth and what's going on in Georgia with regard to telemedicine.
Fantastic. Thank you, Megan. And hello, everyone. As Megan said, I'm Sherry Williams. I'm a licensed clinical social worker. So a lot of what I talk about comes from a mental health perspective, but I'm also the executive director for Georgia Partnership for Telehealth. Over the past couple of years, Georgia Partnership for Telehealth has expanded quite significantly. We have a not-for-profit in Georgia, Alabama, Florida, and then we're part of the federal Southeastern Telehealth Resource Center program. So there's a lot of logos. So we rebranded ourselves. We are a global partnership for telehealth. So if you have heard us called any of these other names, I just wanted you to know that we're the same. We are headquartered in Georgia, but we do touch a lot of regions outside of our state and also internationally. A lot of times people want to know what the role Georgia Partnership for Telehealth plays in other companies that are similar to us. We are essentially the conductors of telemedicine. There's a lot of moving parts in telemedicine. Our particular company, we do not employ physicians, but we partner with physicians. We have approximately 600 or so endpoints just in the state of Georgia alone. So that's a lot of moving parts. So we're the traffic controller in the background. We control schedules, we control who's connecting to who, credentialing, scheduling, all of that good stuff. So I like to make sure everyone understands what perspective I'm talking from. This is what our network looks like. It's an open network. If you think of a spider web, once you are connected in our network, you can connect to anyone else in our network. So those 600 endpoints in Georgia can easily connect to each other without any barrier. This is what we look like in Georgia. This map is a little bit outdated, but it kind of shows you how telemedicine is spread throughout. Atlanta and the metro area is heavily inundated. Obviously, our goal when we first started Georgia Partnership for Telehealth was to reach the rural areas of Georgia. And unfortunately, the rural areas of Georgia do not have access to specialty care that we can find in the metro areas. So all those little dots that you see scattered throughout Georgia are our presentation sites, and then the metro areas are heavily inundated with specialists, so we're connecting back into those areas. As Megan said, telemedicine is boundless. We tell people if you can think it, you can almost do it in telemedicine. We see a lot of different environments happening in our network. Primary health care is pretty big in our network, as well as the behavioral health piece, and I kind of lump those two together. I agree with the statistics Megan showed earlier. Most of what happens in our network is largely mental health and behavioral health. And I always preface it by saying that just because telemedicine enters your world doesn't mean that there's just an overabundance of psychiatrists and mental health professionals to go around. There's a shortage in psychiatry, regardless if it's in a traditional method of receiving care or through telemedicine. So I always like to make sure people understand that. Some of the other applications that we're seeing, skilled nursing facilities. We do a lot of mental health and wound care in our skilled nursing facilities. School-based health centers is an area of tremendous growth that we've seen over the past few years. Specifically, probably in the past 18, 24 months or so, school-based health have exploded in Georgia. I think we are right around the 90 mark with school-based health centers just in our state. And then Tennessee has also started adopting telemedicine into their school-based health centers, and we work with them on that as well. Ambulances and paramedicine, and there are several pilot programs around the state of Georgia now in terms of ambulance and EMS care. The goal being in some of these small counties where maybe there's not a hospital and maybe there are only one or two ambulances, if those two ambulances are out of the county transporting patients to adjacent counties where a hospital is, there's people left unserviced in that community, especially if these people that are being transported are non-emergent and you have an emergency comes in. We've had lots of cases where people have died waiting on the ambulance to get there. So the paramedicine program essentially serves those patients who call 911, EMS arrives, they triage the patient, and it's just not an emergency. It could be, an ear infection, toothache, anything like that. Telemedicine is very appropriate for that. So with the patient's permission, those are turned from a transport to a telemedicine visit, and the ambulance is staying in that county waiting on the next emergency to come in. So that's something that is in a pilot phase now. There are some wrinkles to iron out, but it looks like it's going to be a fairly successful program, and hopefully we'll end up saving lots of lives. A lot of people want to know what a telemedicine site looks like. It will look like a lot of different ways. This picture just shows you one of many, many examples. And you can see this is a traditional telemedicine cart. For years, this was the only type of a solution. It was the full cart. The price range on it was $30,000 to $40,000. That is no longer the case. The prices have come down tremendously. There are very small and simple solutions that are small as your PC or your laptop or your tablet. So telemedicine can look 100 different ways in 100 different environments. These are some images. I like to do a live demo, but through the webinar, a live demo is kind of difficult to do. So I'd like to show you some pictures of some of the images that we've taken through telemedicine. The first one is a picture of an eardrum, and you see that little tiny thing in the bottom? That's actually a bug. It's a gnat. And that's one of our employees here at GPT. He fishes a lot, and when he came back from fishing, we were just testing out some scopes that we had received in, and we found a little bug in his ear. So that was kind of a cool picture, and it really shows you the capabilities of telemedicine and what you can pick up in these images. This is just another slide of eardrums. We have a fairly normal eardrum. You can see some redding across the top of that top left image. And then the top right image is an eardrum of a child in one of our local schools here. Came into the school nurse, tugging at the ears, complaining, had a difficult time hearing, it was hurting. She puts the scope in his ear, the school nurse puts the scope in the child's ear and finds this, which she had no idea what that was. She thought it was a spider or something that had crawled into the child's ear, but it's actually hardened, impacted earwax. So through telemedicine, they were able to determine that, and the child was able to have his ears cleaned out and went on to have a healthy ear. The impact of telemedicine is pretty obvious in my opinion. If people can stay within their communities to receive care that they otherwise would not be able to access, they're not driving a long distance to get to specialty. I happen to be in South Georgia, so for residents in South Georgia, we frequently drive to Macon or Atlanta or Augusta for medical care. That's a 3 to 4 hour drive one way. So we're looking at a full 8 hours if we go to Atlanta and back. That's a parent missing a full day's worth of work. That's a child missing a full day's worth of school. By providing telemedicine, we're able to access these things locally, to keep people local, and to support the local resources. If you are driving to Atlanta for a doctor's appointment and there's labs that have to be drawn, chances are you're going to stay in Atlanta and have those labs drawn rather than using the local services back home. So the local medical community likes it because it does keep patients at home. And it keeps them engaged in what's happening in the local community, while at the same time they have access to these wonderful specialties that are available throughout the state. I'll talk a little bit about reimbursement and regulation, and I will preface this by saying that I will be talking largely about the state of Georgia. Some of you on the call may not reside in Georgia and may have questions outside of the state. At the end, if you do have a question, if you'll just type it in the chat box, I will do my best to answer regulation questions outside of the state. And if I don't know the answer, we can certainly get it for you. So one important thing to consider if you're doing telemedicine in the state of Georgia and you're a physician, there's the Georgia Medical Composite Board that you need to go by, the regulations. About 2 years ago, they adopted telemedicine language, and this first slide shows all the musts. You can see each of the bullet points are followed by the word and. So you have to have a Georgia medical license. There are some across the nation. Several states are buying into a telemedicine compact license. Georgia has not bought into that. So if you are doing telemedicine in the state of Georgia, you have to have a current Georgia medical license. You have to practice within your scope. That kind of goes without saying. You have to have patient history available. If I'm going to refer a child to you as the physician, I've got to supply you with some type of medical history on that child. And then on the next slide, you have to meet at least one of the following criteria. And each one of those is followed by the word or. The very last bullet point is the one that I like to really point out because I think it speaks a lot to what the state of Georgia has tried to do with this language. So if you're going to do telemedicine, you have to be able to complete an exam that is equal to or superior to a traditional visit. That means if somebody is complaining of a sore throat, you have to be able to visualize that throat. If there is an issue with the ear, you have to be able to visualize that ear. So the state of Georgia really worked hard on this language. We went back and forth with the composite board. We didn't want it to be so regulated that it made it difficult to do telemedicine, but at the same time, I think everyone agreed that there needed to be enough there so that telemedicine was still done in an appropriate and responsible way that it holds the integrity of medicine. So if you're not familiar with these rulings, I suggest that if you're doing telemedicine in Georgia, that you understand what the composite board is saying. And reimbursement is, Georgia is a very telemedicine-friendly state. Back in 2005, the Georgia Telemedicine Act was passed, and that act put forth Parity Law. Parity Law essentially says that if you're doing telemedicine in Georgia and you're an insurance company and a physician submits a claim for telemedicine, you have to reimburse it dollar for dollar what you would reimburse for if that was in a traditional visit. There are caveats to that. There's always a caveat to everything. So the caveat would be Medicare. Medicare has their own set of rules that we'll talk about in a few minutes. And some of the self-insured policies can write in whether or not they want to cover telemedicine. It is my experience that more times than not, telemedicine is accepted across the board. There's been a few times with some smaller companies, and this was several years ago, that telemedicine was not written into those policies, and it became very difficult for those members to receive care through telemedicine. And I think that is education issue. I think telemedicine still is fairly young, even though it's been around for years and years and years. I've been doing it here at Georgia Partnership. We've been doing it for a little over 10 years now, so it's not brand new, but in the whole scheme of things, it is somewhat new. I think people don't necessarily understand what telemedicine is. You can ask 10 people to describe telemedicine, and you're going to get 10 different descriptions. Our description at Georgia Partnership are those images I showed you. You have to be able to look and visualize various body parts. You have to be able to listen to heart and lung sounds live time. Other people see it as, a simple phone call or just a flat video, some like what we're doing today and interviewing back and forth. So with education, reimbursement has gotten better in our state. Back in 2012, DCH, the Department of Community Health in the state of Georgia, created the very first Telemedicine Handbook, and it went through all the rules and regulations that they required for telemedicine to be reimbursed. It clearly defines who is eligible to bill through telemedicine, where the appropriate telemedicine settings are. That was revised earlier this year, so if you have an older version of the DCH manual, you may want to go and make sure that you've updated to the 2016 version. Some of the locations in Georgia that are approved, hospitals, FQHC, school-based health centers, health departments, and that list goes on. CMS is very, very different. They have very different guidelines. And my advice to you, if you are going to do telemedicine and you're going to bill Medicare, the address of where that patient is located is what matters. So before you engage in a relationship with a patient through telemedicine who has Medicare, check that patient's address. It may be the skilled nursing home where the patient resides. It may be a clinic that they're going to see you through telemedicine. But that specific address is what matters, and that's going to determine whether reimbursement will occur or not. As I mentioned earlier, several years ago, Georgia Partnership received a federal grant, and it's part of the Telehealth Resource Center. We're the Southeastern Telehealth Resource Center, and it's a free service for anybody. We cover Georgia, Alabama, Florida, and South Carolina. So if you're within those 4 states and you have questions about setting up telemedicine in your particular state or in your particular environment, call our resource center. We will help you. We will consult with you, and if we don't have the answers, we will send you to the person that does. We also have the National School of Applied Telehealth. This is a certification course that's offered through Hometown Health University. If you are new to telemedicine or you're thinking about getting into telemedicine, these are certification courses. You get a little certificate or CEUs that go with it that goes through the fundamentals of being a presenter or a coordinator. And that is just a snapshot of what telemedicine looks like in Georgia and what Georgia Partnership for Telehealth does. Megan, at this time, do you want me to throw it over to Anitra?
about 8 years now. And recently, within, I would say about the last couple of years, we've been doing this program called Street Medicine, where we actually go out into the streets where our patients are to try to offer medical care. So I'm going to kind of go through a little bit of what Mercy Care is, and then a lot of what we've done with telemedicine out in the street. Okay, someone can't hear. Can you hear me at all? Okay. I will try to talk louder. All right. So Mercy Care is a federally qualified health center. Here's a list of some of the different services that we offer. Our main service, of course, is our primary care. We focus on a lot of chronic diseases. And what makes Mercy Care a little different is that we actually have the Healthcare for the Homeless grant, and that allows us to really focus on the homeless population. I think last year we served about 60%. 60%, I'm still trying to get my volume up, 60% homeless population. So they're a big part of our focus. Some of the other specific programs we do are related to infectious disease. We have a whole primary care devoted to HIV, individuals who've been diagnosed with HIV but need ongoing primary care. And recuperative care is a 19-bed facility at a shelter location where we take patients leaving a hospital, well enough to be discharged from a hospital, but are homeless and would likely relapse if they were placed back onto the streets. So we take those folks in and offer them services. We also do dental, vision, x-ray, and what's my world is behavioral health. And that's where kind of street medicine was born out of. You can also see just a little blip of our budget, and we're really an unfunded program for the most part. A lot of our patients are uninsured, so about 6% comes from patient revenue for what covers our total costs. So Telestreet medicine, there were two main purposes in us doing it. One, to try to really expand primary and subspecialty healthcare to folks living under bridges out in the environment. We really wanted to focus on the unsheltered, so even not the folks living in a shelter environment or in transitional housing, but really focusing on those out living in the streets from day to day. And it was also a way for us to encourage providers to volunteer from the comfort of their own home or their own office. So get more providers out there to get interested in this type of service and do it in an environment that was easier for them to do from. So just a little logistics. We go out typically one evening a week to the streets of Atlanta. Our team consists of those folks there. We've got, really important on the team is our outreach RN. She kind of is the glue that holds the whole team together. A lot of scheduling and figuring out which patients we need to follow up with. Another really important member is our outreach guide. This is a person who has been previously homeless, and he really understands the streets. He's our guide to the streets. He lets us know where we can go, where we can't go, where the hot spots are, and those kinds of things. And then we've got our providers, our psychiatrists, our PCP, and we've got a few students from some local universities that we've partnered with. We also go out once a week on the afternoons with another outreach team, and we connect to the psychiatrists via telemedicine. So a little bit about client engagement. It's really important not only for telemedicine in general is a challenge to really engage folks and get them comfortable in receiving care from this type of medium, but also the folks that we're serving. If you can imagine, we're serving the truly vulnerable, really marginalized from society and very untrusting of a lot of society. So trying to engage those folks is a challenge at times, and a lot of times we'll bring out different things like hygiene kits, food, just things to really get them to feel comfortable in meeting with us and hopefully getting care. We weren't able to show a video that really portrays this well, but I did want to share a brief story with one of our providers, Dr. Bamra. She was like 8 months pregnant, going out doing street rounds with us, so out in the environment, walking with her belly, and she met with the patients there on the street. So a lot of the patients got to know her as this pregnant woman getting ready to give birth any minute. And then once she had delivered the baby, a few weeks later, she was able to come back and be part of street medicine, but through telemedicine. So this same patient that met her out in the field and with this belly then got to meet her again through telemedicine for follow-up care. And he actually, while she was providing the care, her baby was with her. So the baby was able, was making noises and things like that, and the patient was able to see that this baby had been born, and it was kind of this moment where they connected and felt like they were a part of each other's lives, from this person going into the homeless individuals' homes, in a sense, on the street, and then them also getting to see Dr. Bamra in her home with her baby and kind of her lifestyle as well. So it was a way that we kind of helped to build that engagement and build that trust in a different way that you really can't do in a clinic setting. Here's a little bit of the workflow for our street outreach. Typically, so they're out on the street, the RN will notify the provider if there is a patient that needs to be seen. We do have an electronic medical record. We use Epic, where they'll log in, they'll check the patient in, they'll do all of the routine stuff that you might typically do in a check-in at an office. And then the student RN will obtain further consent. We have a form that the patient reviews and signs. And the student will also get the H&P and then present that to the provider via the telemedicine. And so the student and the RN will carry the equipment to where the client is sitting, standing, what have you. The provider then interacts with the client and confirms that the H&P that the student just shared was accurate and gives orders through the EMR, tells the RN. We actually take medications out with us during the street medicine so we can provide it right then and there, and fill the prescription and give it to the patient, along with instructions of when we'll be back. We're always constantly encouraging our patients to come into our clinic because we want to provide a more comprehensive care, and we have far more services in our clinic than we do out on the street. So that's always a part of the process too. And then for our psych assessments, it's very similar. The main difference is that the student is not as heavily involved, and the RN really focuses on doing some different symptom questionnaires. We use, for example, we use the PHQ-9 or the GAD-7. Those are for depression or anxiety. And then she'll report those scores to the psychiatrist. But the psychiatrist will really take over at that point and do further assessment to determine what medications are needed. Again, give those orders through the EMR, and the RN will give those medications out right then and there. So just to give you a picture of the equipment that we use, because we have the primary care providers as part of our team as well, we've got a lot of the scopes and things like that that you can see there. We have the HP notebooks. Mostly on the street medicine team, though, they're using the Surface Pro tablets. We've found those to be great because they're so lightweight and just mobile for us to use, which a lot of you probably know what that looks like, but it's similar to an iPad for those of us that use Apples. And then we've got our MiFi with us as well, so we can be connected to the internet out in the field. So here's an idea of our numbers. On average, we have just a few visits a month related to telemedicine. The last few months, we haven't had any medical visits, but we've had about, for example, in March, we did about 6 encounters related to psychiatry, and in April, we did 5. So typically, we'll do, because we go out on average about 3 to 4 times a month, we'll have about 5, 6 visits on average a month as well. So here's some of our successes. Definitely, we have had some volunteer primary care providers available at almost every street rounds. So usually our biggest struggle, because we don't have a dedicated primary care provider to the team, like we do our psychiatrist, but we've been able to pull in volunteers and kind of entice them through using telemedicine as an approach to get them, to be able to do it from their homes. It's also, again, that reduced stress for the volunteer by participating from their home. If you could just, Dr. Bomra's example is great, because I'm a mother of 2, and especially when you have a new baby at home, it's just nice to be able to go put your baby down, do a little work, and then go right back to your baby. So especially as a volunteer, you're more likely to volunteer your time when it's easy for you to do. It's also, we did a few surveys and found out that it is high level of consumer satisfaction. I don't know the total scores or the average score that we received, but I know that the scores were very high for those that we served. And part of it, too, as a success, was making it through a lot of the challenges and frustrations that I'll talk about in a second. So here are some of the challenges. Our psychiatrists and our RN quickly became our go-to IT people, which probably isn't the best thing to do. And so at times it was frustrating because it was stuff that was over their heads, and they full-heartedly admit that. There were times we weren't able to connect when we needed to, and so there was those challenges. Sometimes our equipment that we had and the software wasn't working together. What I learned from all of this was we came together with Georgia Telehealth. They were able to really kind of provide us some direct service, some hand-holding, figuring out with our IT people that are trained to do this job. They were able to really figure out what the problems were, what we needed to do differently, so that we could make sure the connectivity and some of those equipment software issues were resolved. There were some workflow issues in the beginning that we've worked through, trial and error, especially being out on the street. Things change so frequently, but these were things that we were able to work through as a team. And then a lot of, for example, with our RN, there are several tasks that she has to manage at the same time, from wearing a registration hat to wearing a hat that to take vitals and technically rooming people so that they can be put into the system. So, she has to wear several hats, kind of managing the group and making sure that everybody is doing what they need to do can be a challenge. So that limits the number of people that you can see in any given time for us out on the street. And then, of course, those clients with severe psychotic symptoms really weren't conducive to telemedicine. There would be fears of looking at the equipment and, thoughts of paranoia that someone was trying to hurt them through the equipment. So those types of things we had to work through or make a referral into the clinic, trying to get some of our outreach staff to come bring them into the clinic to be seen in a more traditional setting. I think that is it. So
great. So I guess when an organization that is just beginning that implementation process, they've done their needs assessment and they have an idea of what services they want to be providing, how do they develop those relationships to either, if they're one of the distance sites, identify the presenting sites who may come to them? Are they able to work with some of the existing patients that they have with their practice, I guess, depending on location and everything? How does that process work?
No, absolutely. So I'll start off by saying telemedicine is not a situation where you build it and they will come. Telemedicine is great, it is fabulous, it is very sophisticated, but if you are not serving a need for your community, no one's going to use it. So the first thing to do is do a needs assessment. Where are your gaps? What are people having to leave your community to go seek, or having to leave your practice to seek out? And can telemedicine fill that gap? And a lot of times I think the answer will be yes. So once you've identified that area, then you really need to get down to the nuts and bolts. What is your, consult your IT people. What is your bandwidth? If you don't have good bandwidth, you're not going to have a successful telemedicine program. And you have to have a champion on your site that is going to run with the telemedicine program. If you have a nurse or an administrator or whoever that person is, fill in the blank, that is not supportive of the program, they're not going to want to use it, and they're going to refer people outside of the telemedicine realm. So make sure you have a champion. Make sure you know what problem you want to address, and then make sure you have the infrastructure to support it.
Great. So that sounds like it takes a lot of planning and coordination, but based on your experiences, those are challenges that can be overcome and streamlined so that the practices get used to providing those services and flexible to the way that they want to do it. So it's great.
Sure. And this is where Georgia Partnership comes into place, and this is what we're very good at. As I mentioned earlier in my talk, there are lots of moving parts and pieces with telemedicine. In our particular case, there's 600 endpoints with 600 schedules and 600 people trying to do 600 different things.
So I want to also talk about some of the challenges that practices are going to face, and some of those getting to that kind of that gap between what we're hearing and all the excitement, and kind of gives off the idea that everyone's doing it, but we know that there is that gap with utilization. So what are some of those factors that are contributing to that gap, and where do we really need to make some improvements to increase that utilization?
A lot of our network, we manage that. When we're talking about workflow in a practice, there's a number of ways I've seen it work. When we're talking about physician schedules, sometimes physicians want to block off time. They want to have telemedicine clinic days, especially our specialists. Mental health, we do some pediatric GI stuff, and lots of other specialties. Those doctors want a specific schedule. So, for instance, every Wednesday from 9 until 12, Dr. Smith knows that he or she is going to be sitting in front of the computer doing telemedicine for 4 hours or 3 hours or whatever. Other doctors like to work it into their schedule as a walk-in basis, especially primary care. The doctor is there, he walks into exam room 1, sees the traditional patient, goes to the next exam room, sees the traditional patient, goes to the next exam room, and sees the telemedicine patient. And it just works into the workflow that way. So I've seen it both ways, and it works both ways. It really depends on the environment and the climate in that particular practice. And everything that you said. That's how it works. So in some examples, we have a couple of very large hospitals in the state of Georgia who see patients from everywhere. When they started their programs, they sort of wanted to tiptoe into telemedicine. They didn't want to be open up to any and everybody in the network right away. They wanted to really develop a protocol and a procedure and a process for how it was going to work. So they went through their existing patient load, and they knew that in the next 30 days, 4 patients from South Georgia were going to be driving in to see them. So rather than those patients driving in, they offered those patients a telemedicine option. So that is one way that I've seen it work very, very well. Others come to us, they feel that telemedicine is how they want to start turning their practice around, or maybe they're wanting to get out of the traditional primary care setting and they only want to do telemedicine.
Right, and yes, we have had a number of conversations about that, and wanted to draw the audience to some of the videos that we partnered on with Morehouse School of Medicine, Georgia Partnership for Telehealth, and Mercy Care, and we created an animated video that kind of explains telemedicine from a patient or consumer perspective. So what is it? How do you get it? In many states, insurance reimburses for it or covers it. So ask your healthcare provider if they are providing telemedicine. And the ones with Mercy Care talk about some of those specific situations with the patient engagement and the physician that Anitra mentioned earlier, and making that connection, and focuses on the street medicine program, and how great the work that they're doing is to advance health equity with that use of telemedicine. So I think we're having technical issues because I also haven't seen any questions in our chat box, which surprises me because usually our audience is relatively engaged in asking questions. So I'm going to assume we're having some technical issues with that. So let's talk about that one last question. You did talk in your presentation about reimbursement, but I would like to get a little bit more specifics, especially with behavioral health, since we are seeing so much utilization with that. Can you talk about how, at least in Georgia, some of those behavioral health services are reimbursed for, and if there are ways that we can advance the policy to support the services that we want to be providing and getting paid for?
You saw the map earlier that I showed you. We have telemedicine scattered throughout the state of Georgia. But just because it's available doesn't mean everyone knows it or understands it. We have practices, large practices, usually medical or academic facilities, who have a wonderful telemedicine program. But literally, we had this situation about a year ago. On the 3rd floor of one of our hospitals, they had a telemedicine program that had been up and running for a couple of years. Very successful telemedicine program. Oh, it's okay. And directly on the 2nd floor, literally, the telemedicine suite is here, and directly underneath is this physician. And this physician underneath on the 2nd floor wants to do telemedicine. So he reaches out to us, hey, I want to buy all this equipment, I want to do this, da-da-da-da. And we're like, wait, do you know that on the floor right above you, there's a wonderful, beautiful telemedicine suite that you can book time in and use? He had no idea. I think lack of utilization comes in large part from communication and marketing the program. If you are separated literally by a ceiling and a floor between you and the telemedicine suite, there's really not a good excuse for either one of you to know that the telemedicine department should know that that physician has a desire to do telemedicine, and that physician should know that telemedicine is already available at that facility. So there's some disconnect there. We also have a hard time reaching the general population. We do a great job of reaching out to the medical community and marketing telemedicine and educating about telemedicine, but it's not so easy to reach the general consumer. Megan and I have had this conversation several times. How do you reach the general community? You know, we do as many television interviews as we can to make sure that telemedicine is talked about. But we really have a problem making sure that that general consumer knows that telemedicine is available, knows that they can ask their physician if they're being referred to a specialist somewhere, is telemedicine an option for me? And if so, how do I access it? So I think we have to reevaluate what's happening, the reason for underutilization, because there is a tremendous underutilization problem. And then we need to attack it. And I think getting to that general consumer probably would be the #1 remedy in getting people in front of the camera and using telemedicine.
Great, thank you. So it looks like our time is up. I want to thank you, Sherry, and thank you, Anitra. I don't know that we were ever able to get you back up, but thank you to our audience as well for joining us. And if you have additional questions, you'll be getting some post-webinar emails, and please feel free to reach out to us with the TCC at Morehouse School of Medicine and to Sherry at GPT. So thank you, everyone, and have a great afternoon.